Good morning, and thank you very much for waking up so early in the morning. We have a special guest for the early morning session, Dr. Parham. He will have a lecture on soft tissue tumors and next-generation testing, integration of histological and molecular findings. As you know, Dr. Parham is the Director of Anatomic Pathology at the Children's Hospital in Los Angeles, and he's a worldwide known expert in soft tissue tumors and has dedicated his life to educating others, trainees and pathologists. So we are very lucky to have him this morning here. Thank you very much for accepting to talk, Dr. Parham. I have two small announcements before I let him talk. One is that this is an interactive session, so when you come to voice your opinions about cases, please use the microphone. And then the second one is that we have to be done at 8 sharp because the platform session is starting at 8 sharp in this room. So thank you, Dr. Parham.
Thank you, Sanda, for asking me to talk, and thank you to the SPP. And on this St. Patrick's Day Eve, I just want to say for my Irish friend and knows at least of some Irish descent, like myself, Éireann go bragh. So let's get ready for tomorrow. I hope everyone brought some green to wear tomorrow. So we're going to talk first. I'll just give a few preliminary remarks about what's happening in pathology these days. Indeed, it's a big bang of information. If you look at the information that's come down through the years, I mean, we start out in ancient Greece with people like Galen who are studying in Rome, and then you have this big gap over this era of the Dark Ages, and then in the Renaissance we start doing autopsies in Italy and places like this. And then all of a sudden in the 19th century there's this big burst of techniques that allow us to go deeper. And then now in the 21st century we have next generation testing, which has seemingly tripled the amount of information we get now, where now we seem to be in this era of pathology discovery that is more along the lines of a exponential curve. If you do it in math, the amount of data we get these days is exponential. And we even have created a lot of new entities. No longer are we worried about the cell of origin as we were during most of my career. The cell of origin seemed to be of great importance. Now we worry about what the gene fusion is for a variety of entities such as we see here. So indeed, as we approach this, I think we're becoming more and more like the nerds in the Big Bang Theory who have to study this stuff sort of as a 24-hour discipline just to keep up. It takes me about an hour to sign out one of these reports now to do all the literature review that I have to do to sign one out. So with the first case, we have an 11-year-old girl who presents with pelvic pain. She has a right ovarian cyst, and here's the picture of the cyst that was removed. And as we see here, this is a sarcomatous lesion with a biphasic pattern. You can see some of the more glandular-looking areas here and the stromal areas here. And I like this picture from the Norton Simon Museum of Syrah, the stone breakers, because that seems to be what we're doing, breaking these things down into finer and finer pieces. So now we'll go back here and just have people come to the microphone and talk about what they think this is. Have any takers? I thought I was going to be filmed, but actually it's just going to be the slides that are filmed. Not me, so didn't have to get dressed up, I suppose. But I was planning to threaten people to bring them up to let them be filled if I didn't get any opinions. So ovarian tumor biphasic, sarcoma looking. No takers? Sanda, I guess you're up. Okay, well, was anybody get any immunostains to work this up? Which ones would you get? Okay, cytokeratin's a good idea. Inhibin alpha. Okay, very good. Here's the inhibin alpha, which stains selectively the epithelioid appearing material. And here's another one, calretinin, which also has focal staining of this epithelial area. So what do you think now? Sertoli Leydig cell tumor. Very good. So we did the next generation testing, and here's the results. We have this 2 mutations in the Dicer gene. And indeed, Dicer is now recognized as a marker of Sertoli Leydig cell tumors in children. There's a penetrance in this particular case of about 25 to 50%. And indeed, the brother and the mother were found to be positive, or negative, and the father was found to be positive in this particular patient. So she apparently has a inherited mutation and then a second mutation. So the integrated diagnosis in this case is Sertoli Leydig cell tumor, positive for Dicer1 mutation with confirmatory Sanger sequencing. And indeed, we now recognize this as being a marker, that's a consistent marker for moderately and poorly differentiated Sertoli Leydig cell tumors, as we see in this particular table. And as you see, out of these cases, the ones that were originally unanimously diagnosed as Sertoli Leydig cell tumor, 17 of them actually had a Dicer syndrome. All right, we'll go to the next case. This is a 15-year-old girl with a left tibial tumor and enlarged inguinal nodes. Here is an x-ray of this lesion. You see it's a large destructive lesion of the proximal tibia, better seen on the MRI than on the x-ray. And we again see epithelioid cells enmeshed in this fibrous appearing stroma, and in some areas it appears to be producing a hard pink stroma that envelops the cells, and as we see here, there has in some areas even a lace-like pattern. I think here's an area here where it almost gets lacy. As we see here, they do seem to envelope individual cells. So another scene from L.A., this particular one being a movie I'm sure we're all familiar with. So what would you think now? What would you do next? Bone tumor, epithelial and small cell features apparently producing a pinkish stroma.
Do a SAT-B2.
SAT-B2, very good. Sanda, score. Very good. Here's the SAT-B2, strongly positive in about every tumor cell. Anybody else want any others? Let's go back to the last case, because I didn't get to show the cytokeratin on that case, so I'll show it on this one. This one's CD99. What do you think, positive or negative? Like CD99 sometimes is, it's hard to interpret. It seems to outline some cells, not others. The NKX 2.2, which I rely on more for this type of tumor because it is a marker of the fusion gene. It was completely negative. So I felt confident that this was not a Ewing sarcoma. And cytokeratin just shows just a little focal positivity, and EMA's locally positive. Anybody have any thoughts about that?
You don't have to be right. Just come at the microphone or just sit there and voice your thoughts. And the idea is to get a differential diagnosis so then we can explore it further.
Yeah. By the way, I'm 3 hours behind, and add on to daylight savings, we have, I think I'm behind you guys, so most of you, so we'll... Okay. Here's a reliable person. Thank you. What do you think?
My hasty Googling tells me that SATB2 is a marker of osteoblastic differentiation, which I did not know. And based on that and the morphology and clinical presentation, I want to call it a small cell osteosarcoma.
Score, because that's what I said. However, the tumor does not respond to osteosarcoma therapy. An outside consultant performs FISH, which I didn't do because the NKX 2.2 being negative, I felt it wasn't a fusion-positive lesion. So it wasn't a Ewing's. So an outside consultant calls it Ewing sarcoma, and additional genetic testing is pursued. With the chromosomal array, as we see here, showing multiple losses and gains. Can you guys read these? Okay, well, I'll just kind of point it out to you here. Actually, it's easier to read this side than this. But you see relative loss and gain here at the bottom. So multiple chromosomes are lost or gained. So that is certainly part of osteosarcoma as we think about the process of chromatripsis, where there's a catastrophic chromosomal breakage that goes through attempted chromosome repair, and then there's a progression towards cancer. And before I do that, let's have someone. You were going to speak there for a second.
We just phoned some friends since nobody's had enough coffee yet. Did you do MUC4?
MUC4? No.
Sclerosing epithelioid fibrosarcoma?
It's a good thought. Excellent thought. Thank you. I don't recall whether I did it or not, but I have seen that lesion involve bone. It's a good point. SATB2 is good for that. Yeah. Okay. So this particular one was negative for ETS fusion and negative for FOS-ETS, which is the alternate, rarely alternate for the EWS fusions in Ewing sarcomas. Of course, this gave me some comfort that it was not a Ewing sarcoma in spite of what the other pathologists said. But what is it? That's the question. What is it? Any thoughts? Ewing's? Sorry, come to the microphone.
Sorry, David, I was being lazy.
That's okay.
It was too far to walk. So there are other Ewings to other gene fusions, such as NFAT-C2, that can give you nested architecture with a small cell pattern.
Okay.
So I would be thinking about Ewings to non-ETS gene fusions, including specifically NFAT-C2, which can give you kind of that patchy weak.
NFAT-C2. Very good. So that's a good point there, that you do have sarcomas, small cell sarcomas that have non-ETS tumors. Would you call this then a Ewing's-like tumor? I believe that's the category that's been placed in. Ewing's-like sarcoma? How would you sign it up?
Historically, yes, that was considered the Ewing's-like category. Now it's just the tumor gene fusion, so if you can get that, but yes, historically Ewing's-like tumor.
So a great example right there, the lady said just now, we don't say Ewing's-like tumor, we call it by the translocation, which is exactly the point I'm making. showing you the ascendance of genetic testing into our work life. Well, outside fish was performed, and this one actually had a rearrangement of PO5F1. So now what do you think? The lady knows her sarcomas. Myoepithelial carcinoma, right. So this particular one had an integrated diagnosis of myoepithelial carcinoma of bone. I have to admit, this is the first case I'd seen. I had not considered that diagnosis, even though retrospectively I remember they do mark for keratin. They do mark for S100. I believe this one might have been negative initially, and that fooled me. But here we have a case where the immunostains are confusing, but yet in this case, fish testing. This does bring up a point, though, that next generation testing is not the end-all, be-all, because as we have to pick every conceivable fusion to go into the panel, and time marches on. So if you design the panel and it's not something you considered as part of your workup, then it won't be part of your panel either. So these are rare myoepithelial tumors that have a variety of differentiation, typically have this combined epithelial S100 and actin expression, and about half of them have a PO5F1 fusion. So this would not really be a Ewing-like sarcoma at all, but a myoepithelial carcinoma, which explains why it had a lymph node metastasis. So,
how can we explain that SATB2 protein expression in this context?
well, if you think about myoepithelial carcinoma, and actually Fletcher's paper on this subject showed that they are capable of producing cartilage and bone. So, a little worrisome because we typically have a bone-forming tumor and we stop because it's got osteoid. But this one didn't have quite all the features, but they do sometimes show chromosomal gains and losses. That's actually typical of carcinomas. So, that's a tricky case. Let's go to the next one. I'm right on time. This is a 14-year-old girl who has anemia, fatigue, angioedema. We recognize these, of course, as B symptoms if we're talking Hodgkin's disease for you hematopathologists out there. Night sweats, elevated SED rate, elevated C-reactive protein, cold hemolysis, appears to be very infected and sick, or certainly there's some sort of inflammatory process going on. The workup eventually reveals a right adrenal tumor. As we see here now, this is not my area, and I have to admit ultrasounds are difficult for me to read, but at least I know what the liver looks like. And there's the liver, and you see there's a tumor there. So this was a large tumor, retroperitoneal, above the adrenal gland, or affecting the adrenal gland apparently. And this is the photograph of this. So we have these epithelioid cells enmeshed in this inflammatory infiltrate. As we see here at higher power, the inflammatory cells are a large proportion of this tumor. And we also see that these cells have distinctly epithelial features that seem to be making clusters. In other areas, they're just sheets of inflammatory cells with little or no tumor. And now we come to this beautiful LA landmark, the Disney Music Hall. This is kind of like I'm feeling right now, as a matter of fact. So, what do people think about this lesion? A lady with inflammatory symptoms, an inflammatory tumor, and what appear to be epithelial cells What would you think? Okay, angiomatoid fibrocystiocytoma. Any other thoughts? Let's go back a minute. All right. No one thinks adrenalitis? I certainly have to put that in the differential, right? Adrenalitis. Because these cells do somewhat look like adrenal cells. Well, we did these stains. Inhibin was negative. EMA was positive. CK was negative. Others were non-contributory. And so we had an initial diagnosis confirmed by 2 consultants of chronic adrenalitis. I have to admit I was a little disturbed about that particular diagnosis because it didn't make sense to have adrenal cells that were inhibin negative. So, anaplastic large cell lymphomas, another possibility here. Well, we had an interesting fusion study that was part of our next generation testing, and indeed we did have a few cells that had this EWS, ATF fusion, but it was a small number, just above our cutoff for actually reporting. So with that, there was some doubt upon the diagnosis still. Because they said, well, maybe this is an artifact of some sort. There's only a few cells positive. But indeed, after this lesion was eventually excised, the diagnosis came back as angiomatoid fibrous histiocytoma. And OncoKids was positive for this particular fusion. So the diagnosis was confirmed, and now we assume that the reason there were only a few signals is because this particular tumor was so full of inflammatory cells that in fact most of these cells that were being read were actually normal. And another point that you have to have a good sample when you do any sort of test. So this is a rare tumor. It can be difficult to diagnose and tends to be misdiagnosed. There are a number of non-somatic soft tissue sites being reported now, including this array of locations. At the time I put this together, this was actually the first case that actually had been ever noted in the adrenal, but now we do have a case that's been reported in the adrenal as well. Some of these patients do have type B symptoms, as you would certainly expect out of a lesion with this many inflammatory cells. So that one I thought was a very interesting case, very unusual case, and it also brings up another thing we're increasingly seeing with next generation testing is to find or to confirm lesions that have not been reported in particular sites, but that might not even have been part of the initial diagnostic consideration. Okay. Next case is a 14-year-old that had a right extremity weakness and a bump on the head. And here is the lesion here. Even a pathologist can see there's something not right about this. And if you haven't seen it yet, there it is right there. Tumor. Now, is it arising from the brain or is it outside the brain is always the question. This was a bump on the head, and actually it seemed to be coming from the skull, and the skull was partially removed, as we see here with this gross photograph. This was cut into slices, which illustrates it even better, this fungating tumor that was pressing into the brain. And microscopically, we see the classic small blue cell tumor with sheets of cells with no apparent differentiation. They have very delicate cytoplasm. They're tiny nucleoli. And interestingly, there's no mitoses here. So, how do you guys approach these tumors? And what would you think of? Any takers? Where's Robin?
I think I go really broad-based on this, so I would be thinking about hematolymphoid, I'd be thinking about melanoma, I'd be thinking about various sarcomas. I'd want to set cytogenetics on it, but frankly, I'm not sure what presents this way clinically.
Okay. So I like to put them into the big four. Hematopoietic, Ewing's, rhabdo. Of course, I put rhabdo first, of course, and neuroblastoma. And then after that, they're less common, but certainly there's a wide array of tumors that can have a small cell look. So we performed, this is the subway I get. Actually, it's not a subway, it's a light train. It goes down into a subway system. Which is a great thing in LA because the traffic is brutal. So here's the CD99. This one I would call positive. Here's the Fly1. We have found Fly1 to be a very nonspecific marker. If we want it to be positive for our Ewing's, we put on the Fly1 because whatever you put on, it'll probably stain. And here's the synaptophysin showing focal staining. So, what do you think now? Robin?
Ewing's versus heme.
Ewing's versus heme. Okay, very good. Very good. Heme would be unusual with focal synaptophysin, I suppose. Yeah?
That's a good point, but I'm not sure. Are those actually tumor cells?
Yes.
Okay.
Here's the fish. How would you read that? This is the EWS fish.
Normal. Yeah, that's not rearranged.
Normal. Those are tumor cells. Those are tumor cells.
It's not rearranged.
Right. No rearrangements of EWSR1. Here's the FUS. We do see, again, this alternate fusion in about 1% or less of Ewing's cases. How would you read that one?
Rearranged.
No rearrangement in that one either. Actually, it was read. Yeah. No rearrangement there either. So, what would be your diagnosis next?
Did NKX stain on this one? NKX 2.2?
Larry, you remember that? I don't think we performed it at that time. We had not added that one. Again, it takes a while to get these new markers online, as you know. So we didn't have that one. Well, my colleague's out in the audience, Dr. Wong, and of course he wanted to call it Ewing sarcoma. And I said, no, you can't call it Ewing sarcoma. The fish is negative. So we had to call it undifferentiated or malignant small cell tumor with features of Ewing's. But it's negative, so we couldn't confirm it.
So, quick question. So, if this was, it's in the CNS. It seems to be extraaxial.
Yeah.
But it's not clear. So, if it touched a little bit the cortex of arising from there, or if this is a lesion there, I would throw in or keep in the differential some CNS tumors too. For example, like embryonal tumors arising in the CNS, like ethanthers, embryonal tumors with multilayer rosettes tend to be more superficial and well defined too. So I will keep in mind the CNS differential diagnosis.
Sounds
too.
like we have a neuropathologist in the audience here.
No, sadly too.
Okay, good. All right, so very good, very good. Rita, what would you say?
No, I not see, sorry. I would like more.
Rita would like more, spoken like a true pathologist.
Be a CIC or a B Corp?
Okay, B core tumor, very good, or chick duct, sorry. I almost said it wrong. Synovial sarcoma, good ones. Yeah, I mean, we were. Cyclin D1, I don't have. You always want more, don't you? Well, you get it all with this test, right? One test gives you everything, supposedly. Okay, good thoughts. Well, here is the next generation testing. So what do you think now? Again, the NKX 2.2, I don't think we did, but it would have been positive. I don't think I showed you that one, or else we didn't do it at that time. But Dr. Wong really wanted to call this Ewing, and I have to say he was absolutely right. This is a Ewing sarcoma with the EWSR1 ERG translocation. All right, we're going to get to that. Thank you. Good segue. Well, you can have unusual fusion points with a false negative in about 20% of these particular fusions. EWSR1 ERG, and remember, that particular fusion has been reported in about 10 to 15% of Ewing sarcomas. Occasionally it occurs with other fusions. Of course, if you have a FUS fusion, which we also did, by the way, because we wanted to be complete, you can still have a negative EWSR1, but that would not be the case here because we did perform it. As was mentioned, it could be a normal tissue that was tested instead of tumor, and maybe it was just an inadequate sample. So anyway, that was apparently what happened with this case, and actually Dr. Antonescu has described this phenomenon in 4 cases that lacked both EWS and FUS abnormalities, both of them demonstrating it on other markers. So when you do the fusion assay in her case, she likes to do the fusions, they were positive. And what happens here apparently is that there's an inversion of these 2 genes. So here's where the break point is, and here's also where your probes are, okay? So normally that particular signal goes somewhere else. But if the break point occurs and then it flips over so that it stays close to the other signal, then the break point would be here for the translocation, and you'd still have 2 signals close together. And that's how she explained that particular phenomenon, just bringing into mind that FISH testing does not always give you the proper answer. We've seen that now twice in these 2 cases. We saw a positive FISH for a non-Ewing's tumor and a negative FISH for a case that was a Ewing. So just keep that in mind, that you can't always be sure that FISH is giving you the answer you need. Okay, we'll go to the next case. Right on time. This next patient is a 2-year-old. She's got a tumor of the left mastoid. She has a history of fractures of the spine. There's other congenital features suggesting a syndrome. And on MRI, she's got a mass in her left mastoid. I don't have a photograph of that, unfortunately, but it filled the mastoid and extended to the tegmen. And we'll have to get Sanda to tell us what the tegmen is. I forgot. But here's the tumor. As we see here, we have a tumor that's largely crushed, a relatively small needle biopsy. I always warn people about these in my old papers. Do not trust cases with fusion where you don't have enough tissue to be sure you have material. However, this is DNA, so crushed cells can still be ground up and tested for DNA. Here's another small blue cell tumor, as we see here. Here's a slightly higher power of this. Sickeningly red on this particular screen. I hope it's not so red. Oh, it looks pretty good there. Okay. So we have a tumor there that's, again, a small blue cell tumor. And, of course, it was a bone tumor. So we had our thoughts about it. This is a lovely thing to go to at least once in your lifetime, and that's the Rose Parade. Does anybody have any thoughts? Small blue cell tumor, same differential we had before, Robin.
I thought so, but I hate that surgeon because, oh my God, that histology is...
Exactly. This was not a great sample. That was a big problem. That's a problem in this case for a poor pathologist. No other thoughts? Well, we have the same differential we had for the other case. Here is the result we got for most of the stains we did. That's why I'm not... This is negative IHC. And if you want to see the panel, let's see, we had Ewing's marker, NKX 2.2, synovial sarcoma markers, bone tumor markers, brain tumor markers negative.
How about an INI-1?
INI-1, I'm getting to that. You don't have negative INI-1s, right? Always positive. Myogenic, the markers negative, and neural markers were negative. So everything's negative here. Lymphoid markers, thank you. Another segue. The IHC was negative in a wide variety of markers, as we see here. I think this is a pretty good panel. All negative. Now, we did have some positives. Thank you, Cinda. Because actually, that was what the INI-1 looked like. So we did INI-1 and SMARC-A1, or is it 2? Maybe it's 2. It's 1. And it was retained, so those are good. CD56 we see in about as frequently as we see Fly1, right, Larry? It's pretty... Doesn't help us a whole lot. Vimentin was positive. Yay for Vimentin. You can always do a positive stain, right? And WT1, interestingly, was positive, as we see here. So we called it a small blue cell tumor with... Actually, this was what the outside pathologist called it. He called it small blue cell tumor with neural differentiation favoring neuroblastoma. And, of course, he sent it to our colleague, Dr. Shimada, who then brought it to me saying, what the heck is this? Because the FOXB2 is negative. Let's see. So, here's our additional information. Outside CGH showed a loss at 6Q. It was negative for MIC-in amplification, negative for ALK rearrangement, and by flow had normal B cells, normal T cells. So, what do you think next? If you're like me, you were stumped. And so I called it, here's the WT1, which was positive. I called it undifferentiated sarcoma, an easy thing to call these days, right? Because you can treat it. It's not a shame. We know we get even the best of us. Do you ever call things? Rita, you're always calling stuff new things. You still use undifferentiated sarcoma. Even Rita calls things undifferentiated sarcoma. So you see, we do have that term, and it is treatable. WT1 is telling us something. Very good, Rita. Very good. Huh? Which one? Sorry, which marker? Oh, which terminal? Which terminal? I believe that was the N terminal. Thank you. Good point. because the gentleman's referring to the fact that we might have a C-terminal rearrangement that would be staining for that particular marker, but not for the N-terminal. This was N-terminal, the DACO marker. Oh, shouldn't mention that. By the way, I don't have any conflicts. I'm not shilling for DACO, and that marker doesn't help us anyway.
Tick ducts are usually positive for, or can be positive for WT1.
What's that?
Tick ducts can be positive.
Chick ducks? Okay, good one. Good thought. Good thought. So, that was in my differential. Yes, but without anything else, I still have to call it undifferentiated sarcoma because that's what we're going to treat those. So thank you. Very good. The gentleman's thinking. Good. And this is what our array shows. A CBFA 2T3. Don't you love it when you can't make a word out of it? Glee S2. So anybody know that one? Ah, good. I didn't know what the heck it was either. But actually it's a marker of myeloid sarcoma. So because of this, we call it AML M0 undifferentiated myeloid sarcoma with this particular fusion. Don't ask me to say it again. And on follow-up, indeed, we had a positive CD117, CD43. Now, CD117 I could live with because I believe Gino has reported cases with undifferentiated sarcoma, and actually they not uncommonly did have a CD117. And at the time, CD43 wasn't part of our panel. The CD43 is a pretty good marker. This particular fusion then is formed by an inversion. There's a total rate of somatic mutations associated with it, although this one did have a 6 abnormality. And this one is found mainly in acute megablastic leukemia, which we had excluded, by the way, because we did a CD161 and we did factor VIII associated antigen, IHC. About 8% of patients with cytogenetically normal AML have this particular fusion, and it seems to be a marker of a poor outcome. It leads to overexpression of the hedgehog-related pathway, which is the reason these tumors develop. And it is common again. Again, this is kind of the same information in a different paper. And as we see in this particular table, they had 3 cases out of this series that had M0. You see that? That's what I wanted to call your attention to. 3 with M0. Interestingly, none of them with extramedullary involvement. So this appears again to be a unique case, something we see frequently now with this particular testing, things that have not been described. In this particular case, the survival of this was worse than that of the other patients, with a 5-year survival of 27%. So my lessons I learned from this case was that WT1 may be a marker of AML, so as Rita pointed out, you pay attention to it. And we, after this case, we put CD43 on our panel.
When you did flow cytometry, you didn't see like an immature hot blast population?
No,
Were there either markers on that flow panel?
I believe so.
TDT was negative too, right, David?
Yes. TDT would not be positive in an AML. So, that one was a tough one. And of course had to write an amended report, and therapy had to be changed completely. Okay, let's go to the last case. A patient, this is an 18-year-old male with scoliosis pectus and knee swelling. He has repeated aspirations, no pathology. The size increases, so steroids are given. By MRI, it looked like osteomyelitis, so he was treated with a panel of antibiotics and debridement, and pathology shows granulomatous inflammation, so he was treated for TB, but the disease progresses in spite of therapy, and the material is sent for the CDC for their review of it. Here's what we have here, a low-grade looking lesion. As we see here, it has these cells on the edge of this apparent area of caseous necrosis. There's the caseous necrosis. There's these epithelioid cells. As we see here, they're very small, bland cells, histiocytoid, epithelioid. They do have this particular features appear to be cracking a little bit on this particular high-power stain. So what do you think? I&I? I&I, the question is I&I done? Good question.
I feel like you're leading us toward epithelioid sarcoma.
Okay, this one is hard to disguise once you present it, right? Because I wouldn't be presenting it if it was TB. TB would not fit into this particular presentation. This is the scene of the Pacific, and the special stains showed AFB was negative, and that INI1 was not retained, and that epithelial markers were positive.
Did you do S100? Did you do S100?
I would be hard-pressed to say, but of course that's a good one to do. Agree. Any other thoughts? Well, you guys are good. This one actually underwent multiplex because we actually did not get a positive result on the uncle kids, so we doubled down on it with this particular test, and it showed that there was this tiny mutation here with heterozygous deletion with a small amount of material, which is outlined here. This is not very exciting to look at, though, so I had to do something to make it look visual. And, of course, that's a problem with genetics. It often gives you more numeric results than visual results, which is not as tasteful to pathology. So this is an accurate method of finding deletions in this particular gene, and indeed it did have a SMARC B1 deletion and was an epithelioid sarcoma. And this was originally described by Dr. Enzinger as a sarcoma simulating a granuloma, just like this case. In his case, out of 62 cases, 16 of them had granulomatous inflammation. Let me rephrase that. Out of 62 that were called benign, 16 of them were called granulomatous. This lesion has various patterns. It can be angiomatoid. It can have the classic pattern. It can be fibroma-like. It can have this particular larger cells with rhabdoid features we recognize as the proximal variant. And it shows variable degrees of loss. Now, the problem is you may get loss, as you do in case 1 in this particular paper, or in about 20% of cases, you may have no loss. So then the question is, what's going on in tumors that have retained fish? And the rationale currently is that maybe in this big, complex molecule that has multiple moieties like INI1, BERG1, all of these are part of this complex that affects the folding and unfolding of chromosomes. And then recently we have a new case. I'm not even going to tell you what our new one is, but there certainly is a rationale for calling INI1 retained tumors epithelioid sarcomas. 20%. This one actually did have a loss, so it's not as fun in that sense, because I could have said, it's retained, but actually it wasn't. But most of them do show INI1 loss, 80%. This particular paper shows that some of them have a SMARCA4 bird loss. That was the one I was trying to get, SMARCA4. This sometimes has a somewhat unusual pattern like we see here, and they can be unusual. This particular case had a brachyury positive and turned out to be a chordoma, as we see here, and that one was metastasized. So you got to be aware that occasionally these lesions are actually chordomas, as we see here. So I'm about to run out of time. I want to thank first my colleague, long-term colleague, Dr. Hussain, and the Aspen Conference for allowing me to present these cases, which I did present at the Aspen Conference, which is held every 2 years, no conflicts. And the University of Chicago, which sponsors that particular meeting. I want to thank the Center for Personalized Medicine at the University of Southern California and our own Children's Hospital, these colleagues, Dr. Hemans, who reads the material, Dr. Beagle, who runs the lab and reads some of the other testing, and Dr. Judkins, who runs the whole show. And then I want to also thank my colleagues at CHLA, Dr. Zhou, Dr. Wong, Dr. Schillingford, and particularly Dr. Warren, who's back by herself covering. Poor thing had to do it all yesterday. So I particularly thank Dr. Warren. And I'll bid you adieu, just as I bid the work adieu at Union Station every day. And I'll take, let's see, I think that's it. We have a couple of minutes, maybe.
Thank you very much, Dr. Parham. And if there are further questions, I think we still have a few minutes. Thank you.
Sure.
Dr. Parham, I just have a question about just the practicality of this stuff. What do you do when you don't have enough tissue? I mean, I'm just wondering, you did a lot of stuff here, and I'm just wondering about that.
Well, it depends on the situation. If I'm convinced there's tumor and the initial sections don't have anything, I sacrifice the entire block, because sometimes we just don't get sufficient DNA. And we're finding that particularly with the vascular malformations, which we're also testing because they can be treated if we find PIK3 mutations. And we frequently don't get a good enough sample on sections because it's mostly fat and it's not enough DNA. So we certainly do run into cases where there's inadequate amounts of material, and we just have to give them more material. If there's not enough in a biopsy, we're stuck. We have that situation too.
Thanks for the presentation.
Thank you, Phil.
So you talked about false negative fish. But do you ever see false positive fish where you have, it's not all the cells are positive or 98%, but you see
Oh, absolutely. And we showed an example of that with that first myoepithelial carcinoma, where we have a positive fish for Ewing's.
Right.
It's not really a false positive in a sense, but yeah, you can see cases where the fish will lead you down the wrong pathway. I'll say that. So
if you have, like I had a case recently where both on cultured cells and on fish, the number of cells was just over the level of positivity, 12% and 4.5%. Mm-hmm. So do you read that as positive, or do you read
Well, there is another problem, and that's sort of alluded to by the fact that you have a cutoff, and that is any spread will have a certain amount of nuclear overlap. So I suppose if the spread was thick enough, or the section was thick enough, if you did a paraffin section in particular has this problem because you don't spread the cells, then you will get overlap, and an overlap will look like a rearranged sample. So you've got to be careful. And remember, At 3D, it's really a 3D process, right? Because the nuclei are in 3D. They're not all on the same plane. So that can also be a problem. But I don't tend to ignore, sometimes you ignore that data to your peril too, so be careful. Because it might be telling you something you need to work up that you haven't thought of. In that particular case, it was telling us something, but we interpreted it the wrong way. Okay, thank you. Enjoy the rest of the meeting.